basic important thing is that we set this plan individually for each patient. Yes, so every patient is different, every case is different, every patient has different problems, and also every patient is different as a person, as an expectation, has different diseases. So we have to look at the patient and then think about a treatment plan. The plan should be set based on the latest medical knowledge, because yes, now you're students, you read recent books, recent articles, but in few years you will finish your studies, and then you work as a dentist, and after 10, maybe 20 years, the medical knowledge might be different. So we, as a dentist, as the doctors, we have to stay in touch, yes, with medical publication, new books, and read about new methods of treatments, and take part in medical courses. Yes, after finishing our education. Yes, so as we tell, the doctors should learn all the life. Yes, all the professional life as a dentist. The third most important thing is that the plan is based on the information about patient. Yes, because as I told, every patient is different, has different diseases or no diseases, has different age and different expectations. And the last important part is that we should take into account the current technical and therapeutic possibilities. It means that we have to check this medical knowledge and propose to patients the optimal method of treatment available, not only in our clinic. For example, if the patient has a missing tooth, you can do some solutions. For example, prosthetic bridge, yes, or prosthetic dentures. But you should inform patient about every possibilities. For example, implants and crown on implants. And if you in your clinic don't do implants, you should inform patients that it's possibility to do that, but in the other place. To set the plan of prevention, prophylaxis, and treatment plan, we have to take look for caries risk factor. And in caries risk factor analysis, we should base on interview and physical examination. So sorry for a moment. And factors based on assessed on basis on the interview is hygiene habits, frequency of carbohydrate consumption, exposure to fluorine compounds, socioeconomic status, and concomitant general disease. The first thing we in this scale rate the every habit, every factor in scale point 0 to 2. and 0 means low low risk of caries, and 2 points mean high risk of caries, and 1 point is in medium level. So the first, which we ask about hygiene habits and frequency and duration of brushing teeth, and using additionals like flosses or rinses. Yes. And we point 0 if patient brush his teeth for at least twice a day for 2 minutes. 1 point if it's once a day, and 2 points is if he brush his teeth occasionally. Second factor is frequency of carbohydrate consumptions, and we ask about number of carbohydrate-rich meals in 24 hours, and 0 is infrequent controlled consumptions. 1 is when 1 point is if patient eats 5 times a day. It's carbohydrate, and 2 times two meals includes product that stay in the mouth for a long time. For example, potato chips. Yes. And 2 points is the very frequent consumption. Next factor is exposure to fluorine compounds, and the frequency of using fluoride toothpaste and fluoride rinses. And 0 point is when patients use it twice a day, and also use another fluoride compounds like fluoride rinses. 1 point is patients use twice a day only the paste with fluoride. And 2 points is when patients use less than twice a day. The next group is very wide because it's socioeconomic status, and we take up on our consideration education, interest of health, the patient's interest of health, level of cooperation of patients, addictions, availability of dental care, and financial status. And this point is more. We don't have the very tight scale as before, yes, because there was twice a day, once a day. We only rate this as high, moderate, and low parameters, and we should take apart all of this and point the patient. And the last group in this interview is general diseases of patients. Yes, so patient might have diseases that influence on caries disease. For example, if patient has movement problems, intellectual disability, and diseases and medication he takes that lower the salivation, the risk of caries is higher. Yes, for example, when patient has a problem with movement or intellectual disability, he might have just problems with brushing teeth using rinses and things like and that. Okay, and now we have the second part. It's the risk of the risk factors assessed on physical examination, and we check dental caries condition, the presence of active places of initial caries, growth of new caries cavities, gums bleeding, and amount of saliva secretion. The first point is dental condition. We check the number of DMF, yes, so you know it's decay, missing, and fillings. If patient is DMF 0, yes, no caries, no fillings, no extractions, it's we rate as 0. We rate 1 point when the DMF is less or equal to average, and 2 points we rate it is higher than average. And I check in the medical press for Poland, and we have these rates of DMF. For example, also I wrote DMF with small letters because small letters are for children for primary tooth, and the average DMF in Poland is 2.4 in 9 years. When the patient has 9 years, 12 years it's 4.4, 18 years is 6.5, and group between 35-44 have about 20.5 DMF. This group 35-44 is the very common group we check because it's the one of the references group by World Health Organization. So in the medical press you can sometimes see the studies about group in this age. The second factor is are active places of initial caries. Yes, we have evaluate the presence of caries stains. This white spot. Yes, this caries incipiens, macula cariosa in stage D1 according World Health Organization. And we check yes this white spots or brown sometimes with the most moist dental plaque. And 0 point is when there's no caries. 1 point is when one surface is with active caries, and 2 point if 2 or more surfaces are with active caries. Next, we check the growth of new carious cavities. So the DMF, sorry, the P number, it's from Polish part of Polish version of my lecture, because I had the same 2 days ago. P, if of course mean D, like DK, yes, because in Polish it's próchnica, P, D, it should be the number. we check the growth of new caries cavities in 1 year period. Yes, so 0 if there's no caries lesion, 1 if it's 1 new caries lesion per year, and 2 if there's 2 or more caries lesion lesion per year. And to check this, yes, we have to take care of our patients at least a year. We can sometimes have the medical documentation from other clinic about patient, but we always have to know that maybe this examination in another clinic, someone might miss something. Yes, so if we do it personally, we know the patient. I think it's more accurate when we do it. For example, when we have photo, yes, from intraoral oral camera or something like that we can compare those photos. The next part is to rate hygiene status. We use approximal plaque index, and we rate 0 when there is no plaque, dental plaque, 1 if there is less or 30% of spaces with dental plaque, and 2 when there's more than 30% spaces, intradental spaces. And when we check this approximal plaque index, yes, we know we have to check more between 10 and 10 and 20 interdental spaces, and we should check this from both sides. Yes, from buccal side, from lingual palatal side, and we should check lateral teeth and front teeth. So the more spaces we check, this approximal plaque index is better, and it's more accurate to the status of hygiene. The next, we check bleeding of gums, and we use gingival bleeding index, and we check we rate 0 when there's no bleeding, 1 when it's up to or 15% of bleeding in gingival unit, in gingival sockets, and 2 when there is more than 15% of bleeding sockets. The last part we check on our medical examination. We check the amount of saliva secretion, and this is the measurement of stimulated saliva rate. And 0 we rate when this is a normal salivation, and it's about 1.1 milliliter per minute. Or sometimes in other articles you can check that the normal salivation is like 5 milliliters on 5 minutes. Low salivation is about half milliliters to 1.9 per minute, and 2 point we rate when there's very low salivation, like xerostomia and other problems, and below half milliliters per minute. And after this evaluation, based on interview and dental checkup, dental examination. We check our factors, and we evaluate. We check on. We have to pay our attention on those five factors because they are most important, and there are the presence of new active cavities, the condition of the teeth, the use of fluoride compounds, the state of hygiene, and the condition of the gum. And if one of those factors we rate as 2 points, the patient is classified as high risk group of caries. Yes, so example, if this hygiene status is low, we have more than 30% spaces, automatically if other risk we have 1 or 0, the patient is high risk of patient. Also, yes, this 2 new cavities per year. And bleeding gums if there is more than 15% of gingival socket bleeding. So we rate this patient of the patients of high risk of caries. And, yes, we had an examination, and there now we have the next part of our plan of our treatment, and we should always know that the first step is the patient education. Yes, we have to inform patient about the influence of this factor on caries disease. Yes, because we as dental professional and our colleagues, we know it very well. Also, yes, other doctors have the basic knowledge about bacterial dental problem and what they can cause in our bodies. But sometimes patient, especially as I told, we check the socioeconomical status. When the patient has a low level of education, as normal, no medical education, but as like normal, sometimes patient might don't know that for example, the part of his diet and part of his behavior may cause the dental problem. So the education should be the first step. We should also correct the bad habits. Yes, for example, if a patient eats a lot of sugar, we have focus on this to cut the level of sugar snacks. Also, as the correct bad habits. For example, if patient have dental plaque, we should learn him how to clean his teeth. Maybe sometimes patient they can tell they clean their teeth 3 times a day. So if the patient say that, we can ask the patient to get his toothbrush on our appointment and show us how he clean his tooth. Maybe the problem is not in the frequency of brushing, but in the method. The method might be incorrect, and the plaque might be not removing, but also the wrong method of brushing might causes other problem with gums or problem with heart tissue. Yeah. So the first step, as I told, is it's education about influence of factor of our health, of patient health, correcting bad habits, elimination of causal factors. Yes, for example, if a patient has cavities and has dental plaque, so the elimination of causal factor will reduce dental plaque with bacteria, and when we will reduce dental plaque, the the cavity may low. We won't have new cavities on the next appointment in half or year. And the oral hygiene instruction. So we have to learn the patient about correct way of brushing teeth. Also, we should inform about additional hygiene methods, yes, like dental flosses, dental rinses, and recommended toothpaste. For example, when the patient has hypersensitivity, we recommend the patient the paste for that problem, and we should inform about this method and how often, when, for example, in the morning, in the evening, and how much, for example, how amount of the toothpaste, how amount of the rinses, how patient should use this. The second part is professional cleaning treatment, and also we can expand this, yes, on other treatment like sealing and varnishing with fluorides. Also good is the dietary recommendation, yes, just like limiting sugars, sticky food, and acidic products and juices, because they may cause erosions of the tooth. And the helpful in our education might be plaque staining. Yes, so example, patient brush its teeth on our appointment. We give him a color pill. This color pill is dissolved in the mouth. Patient rinses with this his mouth with this dissolved pill, and when the places where the dental plaque is are colored, for example, or pink or red. It's like reddish pill, and the plaque will be colored. Yes, and we try to eliminate the possibility factors and eliminate and minimalize it, because maybe not all the factors we can eliminate. For example, yes, the method of brushing teeth when patients have movement disabilities might be hard to eliminate bad habit, yes, but we can minimize it, for example, by asking someone else to take care of the patient. And we should also, this plan should be adapted to patient, yes, because as we told, the patient every patient is different and has some disabilities, different needs and conditions, and different expectation about health. But we should, if patient expectations are low, we should inform his. We should inform the patient about all problems. Yes, and the last part is preparing the complex plan treatment, and the complex plan complex treatment is surgical treatment, conservative, periodontal, orthodontic, and prosthetic implantology, and so the first step should be surgical remove. Yes, tooth that cannot be treated because there's a risk of cavity on the other tooth. Yes, so we have to, for example, rest black roots removed, and then we could do the second part. Next parts of treatment, we should take care first. We should take care about most important, the biggest, yes, cavities, the biggest problems. And the restoration of the plan. The aim of the complex treatment is to restore the correct function of the masticatory system, and also aesthetic, yes, because as we know, according to the definition of World Health Organization, the health is not only the good condition of the body, but also mental condition, and aesthetic can cause mental, yes, can cause problems of mental, yes. For example, patient has no tooth and he won't smile. He's like on the side of social life, so it may causes problem with health, and as we know, the mental problems can cause the physical problems. So we do full interview, full external and intraoral examination, supplementary examination like X-rays and other checkups, specialist consultations. Yes, when we see the problem, which is not dental, but for example, in maxillary sinus, we having on RTG, we should tell patient to go to specialist. And most important in treatment, in all treatment, all medical treatments, is to set the correct diagnosis. And on this plan, we should consider patient motivation, general health, age, and expectation. And as dentists, we should know that we prepare and present this treatment plan with understanding for our patient, but the patient decide about this treatment. We should suggest the optimal version of the treatment, but we also should give alternative options to the patient. Yes, for example, as I told, with restoring, filling the missing tooth, we can do implants, prosthetic bridges, or removal dentures. Yes, so we should tell patient there's options, and also sometimes the price is very different, and it might be the most important factor to the patient. Patients should be informed about treatment, and patients should agree on this treatment. Yes, we can have this consent of patient verbal, but the best way and preferable is on the writing, because you are safe, and we know that this consent, the patient agree on this treatment. And also, during the treatment, the plan may change. Yes, because we prepare the tooth. Yes, we plan to do filling, but the cavity is very, very, very deep, and we should do endodontic treatment. Yes, so we had to inform the patient about this and change our plan. We should record the visit in the dental, in the medical documentation, and we should write there about everything about visit, and everything about plan changes. Okay, thank you for this